we have a cornucopia of stress testing and different imaging modalities available to us, and sometimes that overwhelms us. So what background can we use to understand this very specific topic about revascularization and stable ischemic heart disease? Single slide on some background in that 2 randomized large trials have shown when we look at angiographic coronary disease as the measure, revascularization was equivalent to optimal medical therapy. This continued to disappoint people with the Berry trial and the Courage trial. Conversely, some recent trials with FFR have suggested that they might be better in guiding PCI as compared to optimal medical therapy. There's a trial that's going to be released, Judith Hochman's trial at the AHA in ischemia. So this is hopefully going to answer some of these questions in the modern era. But with the background to date, what can we do to help answer the question that we were given today? So I'll start with an outline of what we're going to talk about in the next 20 minutes. We have to start with a why. So just framing the conversation around atherosclerosis and how the different test performance will speak to the different types of atherosclerosis, if we've heard from Dr. Fuster, certainly. And then we have to ask the what. What's the question you really want to answer? Are we talking about symptoms or making a decision about revascularization versus medical therapy? And then the how, we'll walk through some of the algorithms of testing modalities and what's the research in for each of the different modalities that support some of those conclusions. We'll touch on the knowledge gaps and hopefully future direction. And then at the end, help us decide what to do when the patient walks in the door tomorrow and we have to make a choice between the different testing and tell them and help them decide what to do. So this is an older slide because it does describe atherosclerosis, but in a very linear, time-dependent manner. As we just heard, and we certainly have read, it tends to be more circular, nonlinear, but it helps us understand that atherosclerosis begins early and can progress, or hopefully not progress. But to answer the question of do we have atherosclerosis, do we have occlusive epicardial disease, each of the different testing modalities will answer a slightly different question. In particular, we can think about positioning some of the different testing modalities along this continuum of atherosclerosis. If the question is endothelial dysfunction, sorry about the spelling, myocardial blood flow and PET is an ideal test. If we want to know about atherosclerosis that's not occlusive and may not be causing symptoms, CT angiography is ideal. It's attacking this part of the spectrum. Symptoms, prognostication, if we're looking, do they have symptoms that are from occlusive coronary disease? SPECT, PET, I don't know why I left echo off of this, but echo imaging would certainly be an ideal test. We're going to hear from Dr. Narula about more sophisticated testing, looking at hot plaque and other areas in this spectrum. But what we have today in our clinical armamentarium, this can help us outline that. The other question which comes up is should we do functional or anatomic testing? A very simplistic way to start to answer the question is, do you want to establish the diagnosis of obstructive coronary disease? Either anatomy or function will answer that question. Are you trying to use this for decision making for revascularization? You're going to need to know both anatomy and function or physiology. So this is from the recent ESC guidelines on stable ischemic heart disease. And it's an excellent algorithm, and I encourage you to look at it. The first 4 steps are pretty straightforward, not dissimilar from our previous guidelines and prior guidelines, assessing symptoms, looking at comorbidities and quality of life. As we heard about, there may be a time when it's futile, and we have to think about palliative care. We sometimes forget that piece. What about some of the basic supportive data? We're going to hear from Dr. Januzzi about some of the biochemistry underpinning that. Pretest probability of disease, we're going to spend some time on that because you can see that in this algorithm, we have to understand the pretest probability of disease of Mrs. Jones when she walks in the door to make a decision. If they have very low risk, we don't need to do any testing. That's a hard decision. If they have very high probability, we can proceed directly to invasive angiography, but we may need FFR or other modalities to look at function. And then in between, low likelihood CT angio has the best negative predictive value, and any of the imaging has a positive predictive value. So if there's a higher likelihood, we might go with a functional test. So I cut to the end. You could leave now if you want, but let me talk a little bit more about the details. Our guidelines from 2014, ACC-AHI, which are being rewritten right now, and I do suspect will be similar, but I have no secrets to reveal, do emphasize the importance of looking at the pretest probability and focusing on this intermediate likelihood, whether it's 10 or 15, and 85 or 90 is important. There was an emphasis on nuclear and echocardiography for uninterpretable or patients who have established ischemic heart disease. Displayed graphically, you can see a similar outline. Important to differentiate if the patient can exercise. There is a 2A at that time, and I'm sure we'll see some difference with CMR or CTA. We're going to hear from Dr. Kramer more about MRI. And then you can see that both pharmacologic MIBI and echo were a 2A compared to routine ECG. Let's see if that standard should apply. This is another graphic display, which I find very helpful, but let's walk through this. And this is from the recent ESC guidelines as a diagnostic pathway, further emphasizing the concept that if you have a low clinical likelihood, patient characteristics, which we'll talk a little bit more about for a CT angio, this may be ideal. They cannot have a history of coronary disease or prior stents. And high coronary calcium is not as helpful because the accuracy of the test goes down with an angstrom over 400. If you have an intermediate or high likelihood, we want to use some of these other imaging modalities. There's always the option for reasons that you would move to the other realm. CT angio is positive, you might need the imaging. The other imaging, you might need to go to CT angio, and then invasive coronary angiography in the high likelihood range. What about other considerations that are embedded in that but are really important for us to think about? Patient's level of functioning, can they exercise, their EKG, local availability and expertise. You're very lucky here. You have expertise in all of those areas. That is not true in most places. It is not true in the community setting or sometimes in the office. Patients' body habitus, obese patients are difficult in most of the imaging modalities. If you're looking for concomitant valve disease, echocardiography is ideal. And then cost, radiation exposure, and patient choice. We sometimes forget, but that conversation becomes important. And then about the patient's pretest probability of disease. Let's talk a little bit about that, and let's do it through a patient who was seen in the office at Brown recently. She was a 45-year-old woman who was a smoker who had left-sided sharp chest pain, hypertensive. Her LDL was certainly not anywhere near what Dr. Fuster was suggesting. What is her pretest probability of disease? We don't have an audience response, but I want folks to think about that. So we can go to the guidelines and look at her age, her symptoms being atypical, and she had all of these high-risk features, and so she was 43%. Her pretest probability was 43%. Most people guess wrong or estimate wrong. If she did not have any of those high-risk features, she would have a pretest probability of 5%. So the importance of age, symptom characteristics, and these high-risk features are important in estimating pretest probability of disease. The European guidelines, and from this recent paper in a larger, more recent cohort, this is just age, sex, and symptoms. You can see a similar low likelihood for this same woman of 6%. The dark green is the group that should be tested. Both this and the PROMISE trial in a more current data set, the probability estimates prior were overestimating. But still most of the data is based on that. So this is interesting also because dyspnea was included as part of this characterization. So what happened to my patient and how does this help us move forward? She was able to exercise on a Bruce protocol. She did develop typical chest pain. Her EKG developed significant ST depression. Her stress echo, I had to show stress echo, of course, showed anterior septal and apical wall motion abnormality. On the 4-chamber view, she had chamber dilation, LAD at least distribution in the 4. This is more of a 3-chamber view. So because she had high-risk features of more than 2 wall motion and dilation, she went under catheterization and had a tight 80% LAD lesion, which was stented. So the point is that stress tests are very good at detecting coronary disease in this group of patients with intermediate likelihood of disease, and imaging in particular are good at helping guide invasive treatment strategies. It also emphasizes the importance going back to Bayes' theorem, and that is we want to test, and we want to test the patients that are not at this low risk because you won't differentiate, or very high risk, the test won't differentiate further, but this intermediate risk, and we want a test that has the greatest ability to change the pre to the post test, either being positive or negative. So let's delve in a little bit to the tests themselves. Functional testing is important. Sometimes we forget about some of the old data because exercise does add incremental information that can inform us and our patients. You can elicit the symptoms, functional status, and there is prognostic information. Older data, but exercise capacity and survival, quite dramatic. Normal subjects, less than 5 METs, greater than 8 METs, the difference in survival. Subjects with cardiovascular disease, similar display of survival based on METs attained on a stress test. So there is incremental information in the exercise testing. Heart rate attainment. Failed to achieve target heart rate versus reach target heart rate. CHD incidence and cumulative mortality. There's pearls of information that are very useful in a functional test. So what about, let's come back to the cornucopia of testing and what can we do to help sort through that? We tend to rely on accuracy, both sensitivity, specificity, positive predictive value, negative predictive value, accuracy, and more recently trying to look at likelihood ratios as a measure of diagnostic accuracy, though a little more complex sometimes to achieve. Knowing the test functions and where they become positive along the ischemic cascade will help inform the sensitivity for sure. It's not surprising that a PET is more sensitive than an ECG, given what it's detecting. Specificity is related not only to the population, but also the functions of the tests themselves. Here's just an example of sensitivity of the typical tests, stress echo, stress nuclear, and stress echo. For multivessel disease, not surprising, their sensitivity is quite high. It's really in the single vessel disease where they really differentiate, with nuclear being more sensitive and the other tests perhaps more specific. This is from a recent meta-analysis looking at over 25,000 pooled data, looking at likelihood ratios. Likelihood ratios are really trying to see if a test result is going to change the probability that the disease exists. And what they looked at was, starting, for example, with a patient with a 56% pretest probability of disease, knowing what the likelihood ratio, let's take the PET, of 5, the post-test probability of a positive disease moves you to a 90% post-test probability of obstructive disease. Look with stress positive or negative ECG. It doesn't move you out of the intermediate range. It is not as useful a test in discriminating and moving for a positive or negative. They also looked at functional significance, FFR in particular, and you can see, not surprisingly, SPECT, PET and SPECT performed well, both for positive and negative predictive values. This is also, their study is also embedded in the ESC guidelines. This seems like a complex slide, but what they've done is they've taken these likelihood ratios and applied them then as a positive and negative predictive value to move from pre-test to post-test probability. And you can see that this is why CTA performs quite well in moving to ruling out coronary disease and ruling in coronary disease, mostly for ruling out for epicardial disease on coronary angiograms and FFR as well. You can see how the other tests can perform both for ruling in red and ruling out in green. I would change the colors, but I wasn't asked. What about accuracy? We've talked about. We can look at, as we mentioned, we can look at both sensitivity, specificity, accuracy, and likelihood ratios. What about prognosis? We have a fair amount of prognosis for a number of these tests. Stress echo, for example. We know that multivariate predictors of events is wall motion score. More than 2 wall segments, abnormalities, will predict events, and low workload. We also know that a normal test has a good negative predictive value with an annual event rate equivalent to age and sex-matched patients. Cardiac SPECT. This is from the Cedars-Sinai group, some really pivotal work looking at, with increasing degrees of ischemia on a SPECT study, there was increasing rates of myocardial infarction in red and cardiac death in green, with the inflection point of changing from medical therapy to cath at approximately 12.5% ischemic burden. And that changed some of the concept of an inflection of revascularization improving survival as compared to medical therapy. What about PET? So SPECT is widely available. PET is newer with limited access, but does have a number of advantages with lower radiation, higher resolution, and the ability to quantify via CFR. This is an example from Dr. Raymond Russell at our institution of a 57-year-old gentleman who is obese with multiple risk factors who underwent a planar stress test. And you can see with the PET scanning a clear picture, clear resolution, and he did not have disease. Looking at reclassification with PET CFR, a very nice way to think about how we can position these tests. Do they help move a patient from the intermediate into a different range? And look at how we can reclassify patients from intermediate to low and high risk with a PET. So this does appear to be a specialized test for flow reserved that may help target revascularization, in particular in patients that are overweight, and ASNEC has recommended them in that particular population group. A recent study just in the last week or two in JACC, very intriguing, looking at over 16,000 consecutive patients who underwent PET scanning at Brigham and Women's Group. And what they found was that their inflection point that favored early revascularization over medical therapy, knowing that it's observational and retrospective, was at 5% ischemia, though the upper bounds you can see come at about 10%. So why would the inflection for ischemia be at 5% in a PET and 12.5 in SPECT? Possibly because of the better accuracy in PET and better resolution. Cardiac MRI, we're going to hear a lot more from Dr. Kramer. Here's an example of a patient who did undergo stress MRI. We had normal function. Perfusion imaging showed a very focal inferior wall motion abnormality, and the patient went on to cardiac cath to have a very significant right coronary artery ischemia. So it's good at diagnosing and localizing coronary disease with a very high sensitivity and specificity. It also has a number of other available attributes, including looking at delayed enhancement and SCAR, and has a negative test, similar to stress echo, low annualized event rate. Also net reclassification, so a test can move the patient that were initially classified as moderate into low or high risk. So this is also important to reclassifying patients and categorizing their risk. Viability and SCAR, we're going to certainly hear more about other potential opportunities there. In the last few minutes, what about the value of functional testing versus anatomic testing? I mentioned early on where you might choose to use this, particularly if you're trying to decide about anatomy and function, particularly for revascularization. As I mentioned, we do know that SPECT and other imaging can predict events, and so we know that at a particular juncture, whether it's PET, SPECT, or echo, you may prefer to move to revascularization, and so having functional testing either non-invasively or invasively with FFR becomes important and part of the guidelines. The PROMISE study was one of the few randomized trials we have that looked at functional versus anatomic testing. It was over 10,000 patients, if you remember, and they had either CTA or functional testing. The majority of the functional testing was nuclear testing, and it was shown that it had lower rates of angiography overall, but did have more angiography performed in the first 90 days after the CTA. So there's some concern there, but in general, coronary CTA is a good alternative to functional testing, particularly in that low to intermediate risk patients with coronary disease and chest pain, with potential coronary disease and chest pain. This is the graph showing that there was no difference in the primary endpoint between anatomic testing and functional testing. So in general, functional testing, though this seems simplistic, but one way to categorize, is great for ruling in coronary disease and guiding therapy. Anatomic testing is preferred for ruling out coronary disease. the two can be combined and give us both pieces of information. Where are some of our knowledge gaps still? The question about medical versus interventional therapy appeared to be answered in Courage and Berry 2D. There's some it's an older study and some concerns about that trial in particular, and hopefully we'll hear more about the ischemia trial and the comparative effectiveness between invasive versus medical therapy in this patient population. We do not have as much data as we'd like to have looking at comparative effectiveness between the different modalities. The studies that I showed you were really looking at separate studies. We don't have a lot of data either randomizing patients or having patients perform the same test. So we don't have direct comparison, and we know that different patient populations will change your sensitivity and specificity. Lastly, what is the application and generalizability of some of the data? Local expertise is very important. It's important to know what your expertise is, what the type of imaging tests you have even available, and healthcare costs, both in the value-based and ACO models that we heard about earlier from your CEO. And it's not just the cost of the test. We need much more sophisticated data. We're just starting to get that from some of our trials. And it's the entire breadth of care. If a PET scan, which costs more money up front, prevents hospitalization and prevents revascularization, which is costly, the entire length of the patient's care is less costly. And so we need more sophisticated ways to be able to answer that question. So in summary, I do believe that the hierarchy of non-invasive testing should be changed. I think we'll see continued evolution of this with the ACC/AHA guidelines, similar to the ESC guidelines that just came out. The why is important. Atherosclerotic progression may be asymmetric, and we need to understand when an imaging modality will help answer what type of question, whether it's endothelial dysfunction or epicardial occlusive coronary disease. The what is important. We have to know what the question is we're asking. Are we trying to sort out a patient's symptoms? Then functional anatomic testing can tell us if they're having symptoms and have coronary disease. Making a decision about revascularization does require both. To do both in a non-invasive fashion is available. You can also do it in an invasive fashion with FFR. The current algorithms do suggest, and I would agree, that coronary CT is ideal for lower risk patients in ruling out coronary disease, assuming you can slow their heart rate, they don't have a high calcium score, they don't have coronary disease. And imaging for higher risk patients because you can rule in coronary disease and assess symptoms. We still have significant knowledge gaps, as I'd mentioned. So again, what are we going to do tomorrow or this afternoon in the office when we see our patients? First, we need to definitely think about the pretest probability of disease. It's easy to have that algorithm, everything's an app on your phone, but thinking carefully about the patient and the cautious history is important. Coronary CTA, if it is available in your institution, it certainly is here for these low to very low risk patients. After discussion with the patients, there may be radiation concerns for younger patients or women of childbearing age. And then if we're making a decision about ischemia, some imaging is preferred, and the type of imaging is dependent on some of the test availability as well as cost, patient preference. And with that, I'm going to end. I'm happy to take questions, and I thank you from our faculty and fellows at Brown.